Welcome to The Explainer. Today, we're putting you right in the shoes of a clinical detective. Because let's face it, when you step onto the medical wards, one of the absolutely most critical skills you're going to need to master is evaluating a patient with suspected heart failure. But how do you take this mountain of complex and sometimes really vague symptoms and systematically prove a failing heart? Well, that's exactly what we're going to break down today. Okay, let's dive into this. Here's our roadmap for the diagnostic journey. We're going to start with building an index of suspicion. Then we'll move through history and symptoms, conduct the physical exam, run some initial tests, and finally look at advanced imaging. So, phase one, the index of suspicion. You know, every truly great clinical investigation actually starts before the patient even says a single word. While you're just sitting there reviewing the chart, you need to build this mental scaffolding. Step one, history. Step two, physical exam. Step three, routine labs. And step four, advanced imaging. It's this systematic framework that helps you master the clinical evaluation, taking you all the way from clinical intuition to definitive objective proof. And this multi-step process demands that you look really closely at specific underlying risks right out of the gate. I mean, if your patient has a history of hypertension, diabetes, or coronary artery disease, your index of suspicion needs to immediately spike. These are the primary drivers of cardiac dysfunction, and honestly, they hand you your initial clues before you even ask that very first question. All right, moving on to phase two, history and symptoms. Now we're actually talking to the patient, and we can broadly drop heart failure symptoms into two main buckets. On one side, we've got volume overload, or congestion. So think dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. But then, on the flip side, we have reduced cardiac output or hypoperfusion. These are your low output symptoms like fatigue, weakness, maybe some mental confusion. It really is a brilliant way to visualize the two distinct pathophysiological states of a failing heart, right? Fluid backing up versus blood just failing to move forward. Now, what's really interesting here is this specific concept of bend apnea. It's a highly specific symptom of congestion that you should absolutely be asking about. Does the patient get short of breath literally just by bending forward to tie their shoes? It's such a classic high-yield clinical pearl, and it points directly toward elevated ventricular filling pressures. So, once you've pinned down the symptoms, you've got to grade them. And the NYHA classification is basically the global standard tool to categorize severity based on physical activity. Class 1 means no limitation at all, while Class 4, that means they're having symptoms even at rest. Do yourself a favor and mentally screenshot this scale because you are going to use it on the wards every single day. Next up, phase 3, the physical examination. All right, this is where you become the on-site investigator looking for hard, objective bedside evidence. Let's start with vital signs. Beyond just noting tachycardia, keep an eagle eye out for pulsus alternans. That's an alternating strong and weak pulse. It's definitely a rare zebra sign, but man, it is highly specific for severe left ventricular compromise. Okay, let's do a quick simulation of a ward round right now. Your attending turns to you and asks, hey, what is the most reliable way to estimate right atrial pressure right here at the bedside? Take a second and think about it. Got it? The answer is quantifying the jugular venous pressure, or JVP. But listen, you don't just passively look at the neck, you actively test the system by performing the abdominojugular test, where you're applying pressure over the liver to check for a positive hepatojugular reflux, meaning that JVP spikes and stays elevated. You can confidently confirm those elevated right-sided filling pressures. Continuing with the exam, you're obviously listening to the lung basis for crackles, or rales, which points to pulmonary edema. Though, a quick aside, keep in mind these might actually be absent in chronic heart failure just because of increased lymphatic drainage. But more importantly, listen really closely to the heart for an S3 gallop. That third heart sound is incredibly specific for volume overload. Systemically, you're going to palpate for hepatomegaly and ascites, and of course, check those lower extremities for pitting edema. Which brings us to phase 4, an initial diagnostic forensics. Let's see how all this builds into our routine diagnostic workup, because those routine labs hold some absolutely vital clues. They aren't just a formality. You'll run a comprehensive metabolic panel to check for renal impairment, which hints at cardiorenal syndrome, but pay special, close attention to sodium. Electrolyte imbalances, especially hyponatremia, are severe warning signs. It's a crucial marker of a pretty poor prognosis. Next, we're looking at the foundational electrical and radiographic findings. Now, while no single ECG pattern is purely diagnostic of heart failure all by itself, finding a left bundle branch block, prior Q waves from an old MI, or maybe atrial fibrillation, that gives you critical context. On the chest x-ray, you're hunting for cardiomegaly, so a heart shadow taking up more than 50% of the chest diameter, and classic signs of pulmonary congestion, like those telltale curly B lines or pleural effusions. And finally, Phase 5, Advanced Imaging and Biomarkers. We've made it to the final phase, where we establish the definitive proof. Time for another rapid-fire pimping-style question for you. What is the absolute gold standard for initial non-invasive imaging in a suspected heart failure patient? It is, of course, the echocardiogram. The echo is the gold standard because it so rapidly evaluates ventricular size and calculates the left ventricular ejection fraction. This is what gives you that definitive categorization, dropping the patient into the bucket of heart failure with reduced, mildly reduced, or preserved ejection fraction. We're also drawing biomarkers, specifically those natriuretic peptides, BNP and NT-proBNP. These are released when the heart wall is under stress. So the crucial point here is this. These biomarkers are highly sensitive for ruling out heart failure in patients who show up with acute dyspnea. If those levels are low, you can pretty much effectively exclude heart failure as the cause of their symptoms. Finally, for those really highly complex cases, we keep some specialized testing in our back pocket. A cardiac MRI is fantastic for detailed tissue characterization, finding scars or infiltrative diseases. And a cardiopulmonary exercise test, or CPET, can objectively measure functional capacity through VO2 max. That's super important to help guide the timing for advanced therapies, like a heart transplant. Which leaves us with this final thought. A structured approach is really what unlocks the mysteries of a patient's condition. By moving systematically, from that initial suspicion, to the bedside exam, to targeted diagnostics, you literally become a master investigator. So will your next clinical exam uncover the hidden clues of a failing heart before the definitive imaging is even ordered? Stay focused, trust the protocol, and you'll find out. Thanks for joining me on this explainer, and I will see you on the warts.